and then this letter from ACOG related to admitting privileges, which was the bill filed by Senator Taylor. Texas ACOG opposes SB 1198 by Senator Taylor. It's dated April 16, 2013. Dear Chair Nelson and members of the Senate Health and Human Services Committee, thank you for the opportunity to present this written testimony in opposition to SB 1198. The Texas District of the American Congress of Obstetricians and Gynecologists represents more than 3,600 physicians and partners in women's health. Texas ACOG opposes SB 1198 by Senator Taylor. While ACOG recognizes that the issue of support for or opposition to abortion is a personal matter and respects the need and responsibility of its members to determine their individual positions, as an organization, ACOG recognizes that abortion is an essential health care service and opposes laws regulating medical care that are unsupported by scientific evidence and that are not necessary to achieve an important public health objective. SB 1198 sets up unnecessary requirements that may be extremely difficult and in some cases impossible to meet without a basis in public health or safety. Requirements for admitting privileges vary from hospital to hospital. The process for approval of admitting privileges can take a lengthy amount of time, sometimes as long as licensure and board certification. We are not aware of other outpatient procedures that require a physician to have active admitting privileges in a hospital within a certain distance. A physician may have active admitting privileges, but not within a 30-mile radius. This is especially problematic for rural areas where hospitals are scarce. Not all hospitals may meet the requirement of providing obstetrical or gynecological health care service. There is not a special designation for hospitals providing OB-GYN services. This provision is vague and could have extensive consequences. Creating unnecessary requirements and criminally penalizing physicians for performing a legal procedure is inappropriate and prevents physicians from exercising medical judgment in order to treat their patient as they see fit. For the reasons outlined above, Texas ACOG opposes SB 1198. It's signed respectfully, Lisa M. Hollier, MD, MPH, FACOG, Chair of the Texas District American Congress of Obstetricians and Gynecologists. A letter, again, from ACOG, this time opposing SB 18 by Senator Patrick. ACOG opposes SB 18 by Senator Patrick, and it's dated June 12, 2013. The Texas District of the American Congress of Obstetricians and Gynecologists, ACOG, represents more than 3,600 physicians and partners in women's health. ACOG opposes Senate Bill 18 because it is a significant intrusion into the doctor-patient relationship, legislating the practice of medicine. This bill unfortunately illustrates the perils of attempting to legislate a particular protocol, increases expenses, and undermines the quality of care for women. First, this bill would require physicians to practice medicine that is not evidence-based. Since the FDA approval of the regimen in this legislation in 2000, additional clinical studies have identified improvements in the treatment of medical abortion. The American College of Obstetricians and Gynecologists makes the following statement in Practice Bulletin number 67, entitled Medical Management of Abortion. Compared to the FDA-approved regimen, mifepristone and misoprostol regimens using 200 milligrams of mifepristone orally and 800 mcg of misoprostol vaginally are associated with a decreased rate of continuing pregnancy, decreased time to expulsion, fewer side effects, improved complete abortion rates, and lower costs for women with pregnancies up to 63 days of gestation based on LMP, the last missed period. The FDA-approved regimen, which this bill would mandate that physicians prescribe for their patients, requires a 600 milligram dose of mifepristone, which is 3 times greater than in the non-FDA approved evidence-based regimen that ACOG endorses above. Furthermore, the misoprostol dose, though a lower dose on face value, is given orally in the FDA-approved regimen, whereas it is administered vaginally in the evidence-based regimen. Oral administration results in higher peak levels of the drug in the bloodstream, which in turn results in greater side effects for women. Vaginal administration not only decreases side effects, but also results in greater uterine contractility. Together, as in the evidence-based regimen, a lower dose of mifepristone combined with a vaginal dose of misoprostol acts superiorly to the FDA-approved regimen. Multiple randomized control trials, which are considered the gold standard experimental design for research studies, have consistently demonstrated that the FDA-approved regimen is associated with greater side effects in women, roughly 3 times higher costs, and lower overall success rates, 92% compared to 95 to 99% success with the evidence-based regimen. The FDA-approved protocol for these medications is no safer than the evidence-based protocols recommended by the American College of Obstetricians and Gynecologists, the Royal College of Obstetricians and Gynecologists, and the World Health Organization. This legislation prohibits, in fact, creates penalties for the act of prescribing a medication regimen that has, in the simplest of terms, simply been proven to be far superior to the FDA-approved regimen. Under this legislation, physicians would face penalties for striving to provide the highest quality of care for the women of Texas. Second, SB 18 places an unacceptable level of control over the doctor-patient setting in the hands of the legislature, essentially allowing the legislature to practice medicine. Again, this bill actually creates a medical protocol for physicians, dictating what medications to prescribe, what doses to use, what to document, questions to ask the patient, and when to schedule follow-up appointments. For example, the bill requires that patients be scheduled to return to the physician that prescribes the medication for a follow-up visit within a specific 14-day time frame written into the law. I absolutely agree that women should have a follow-up exam to ensure a successful termination with no complications. However, frequently this follow-up care is better and more conveniently provided by a primary care provider or referring physician in their own community, particularly for women in remote areas who may have to travel long distances to access specialized gynecologic services. There is a medical necessity for follow-up care, but no medical rationale that this follow-up care must be provided by the prescribing physician. This requirement can create a distance and access barrier for patients with no medical rationale or benefit. Third, SB 18 interferes with the doctor's ability to use his or her professional judgment to determine the appropriate medical care in each individual patient's unique circumstances. Patients have spent years acquiring the specialized knowledge, physicians have spent years acquiring the specialized knowledge, skills, clinical and research training needed to individualize a plan of care for their patients based upon their unique medical, surgical, family, and social histories. It is critically important that physicians have a toolbox, so to speak, to pull from when designing a plan of care for a patient, because we rarely find that one size fits all. For this reason, particularly in the setting of prescribing medication, it is standard medical practice in the United States for physicians to prescribe FDA-approved medicines in doses or contexts that were not specifically approved by the FDA, so long as the alternative use is supported by adequate research. These are sometimes referred to as off-label or evidence-based uses. Every physician has prescribed drugs for off-label uses, perhaps to your wives, daughters, sisters, or mothers. Birth control pills for endometriosis, misoprostol for labor induction, magnesium sulfate to reduce the chance of neurologic complications for preterm newborns. These are all considered off-label uses, standardly employed based on available evidence. Finally, legislation of a single specific medical protocol prevents an opportunity for continuous quality improvement. One of the pillars of medicine is the ability to compare protocols and advance the quality of the medical care that is provided. If this bill were to become law, we would be unable to test potentially better treatments and would need to wait for a legislative session to change the law to implement improvement in care that is developed elsewhere. The bill will not enhance public safety. This bill will not improve the quality of care that women receive. This bill does not promote women's health. SB 18 would deny women in Texas the benefits of well-researched, safe, and proven protocols that currently exist. And it's signed respectfully, Lisa M. Hollier, MD, MPH, FACOG, Chair of the Texas District American Congress of Obstetricians and Gynecologists.